I'll expand all points with more clinical, nursing, and management detail. Here's the detailed version. Pulmonary hypertension. Part 1. Introduction. Pulmonary hypertension, PH, is a chronic, progressive condition characterized by abnormally high blood pressure in the pulmonary arteries, which carry blood from the right ventricle of the heart to the lungs for oxygenation. The increased pressure forces the right ventricle to work harder, leading to right ventricular hypertrophy, dilation, and eventual right-sided heart failure, cor pulmonale. PH is not a single disease, but a hemodynamic and pathophysiological condition with multiple underlying causes. It has a high burden of morbidity and mortality worldwide, especially when associated with connective tissue diseases, congenital heart disease, and chronic thromboembolic events. 2. Definition. According to the 6th World Symposium on Pulmonary Hypertension, 2018, pulmonary hypertension is defined as mean pulmonary arterial pressure, MPAP 20 milligrams at rest, measured by right heart catheterization. Pulmonary arterial hypertension, a subgroup, WHO Group 1, is defined as MPAP 20 milligrams, pulmonary vascular resistance, PVR 2 Wood units, pulmonary artery wedge pressure, PAP 15 milligrams. Tab 3. Etymology. Pulmonary, Latin pulmo, lung. Hyper, Greek over, excessive. Tension, Latin tentio, pressure, strain. Thus, pulmonary hypertension literally means excessive pressure in the lungs. Now 4. Epidemiology. Global prevalence. Estimated 15 to 50 cases per million population. Idiopathic pulmonary arterial hypertension, 2 to 5 cases per million. More common in females, 2:1 ratio. Median age at diagnosis, 36 years for idiopathic, but higher in PH associated with chronic lung disease. High prevalence in patients with systemic sclerosis up to 12%, people living at high altitudes, children with congenital heart disease, Eisenmenger syndrome. Mortality remains high despite therapy, with 3-year survival for untreated IPA 40%. 5. Types, WHO Clinical Classification 1, Group 1, Pulmonary Arterial Hypertension, PH, Idiopathic IPH, Heritable PH, BMPR2, LK1 mutations, drug or toxin-induced, e.g. appetite suppressants, methamphetamines, associated PAH, connective tissue disease, HIV, portal hypertension, congenital heart disease. 2. Group 2, PH due to left heart disease, left ventricular systolic diastolic dysfunction, valvular heart disease, mitral aortic. 3. Group 3, PH due to lung diseases, hypoxia, COPD, interstitial lung disease, obstructive sleep apnea, chronic exposure to high altitude. 4. Group 4, chronic thromboembolic pulmonary hypertension caused by unresolved pulmonary emboli. 5. Group 5, PH with unclear multifactorial mechanisms, hematologic disorders, sickle cell myeloproliferative disease, systemic disorders, sarcoidosis, glycogen storage disease, metabolic disorders, thyroid disease. NAFNR 6. Causes, etiology, idiopathic, unknown. Genetic mutations, BMPR2, LK1, SMAD9. Cardiac causes, left-sided heart disease, valvular lesions. Pulmonary causes, COPD, pulmonary fibrosis, interstitial lung disease. Chronic thromboembolic disease, recurrent pulmonary emboli. Autoimmune diseases, systemic sclerosis, lupus, rheumatoid arthritis. Infections, HIV, schistosomiasis. Liver disease, portal hypertension. Drug toxin exposure, methamphetamines, appetite suppressants, fenfluramine. Number 7. Risk factors, family history of PH, connective tissue or congenital heart disease, female gender, especially idiopathic PH, chronic lung disease, COPD, interstitial lung disease, history of venous thromboembolism, living at high altitude, HIV infection, portal hypertension, drug exposure, cocaine, anorexigenic drugs, obesity, and obstructive sleep apnea. 8. Complications, right ventricular hypertrophy, cor pulmonale, right-sided heart failure, systemic edema, ascites. Arrhythmias, atrial fibrillation, atrial flutter. Hemoptysis, rupture of bronchial veins. Syncope and sudden cardiac death. Reduced exercise capacity and quality of life. Pathophysiology 1. Endothelial dysfunction, imbalance between vasodilators, nitric oxide, prostacyclin, and vasoconstrictors, endothelin 1, thromboxane. 2. Vascular remodeling, proliferation of smooth muscle cells, fibrosis, narrowing of pulmonary arteries. 3. Thrombosis in situ due to endothelial injury. 4. Increased pulmonary vascular resistance, PVR. 5. Right ventricular overload, hypertrophy, dilation, decreased cardiac output. 6. Progression to right-sided heart failure. Number 10. Signs and symptoms. Early nonspecific, exertional dyspnea, fatigue, weakness, chest pain, pressure, palpitations. Advanced, syncope due to low cardiac output, cyanosis and clubbing, peripheral edema, ascites, hepatomegaly, jugular venous distension, loud P2 heart sound, right ventricular heave. Number 11. Medical diagnosis, right heart catheterization, gold standard. Echocardiography screening estimates pulmonary artery pressure. ECG, right axis deviation, RV hypertrophy. Chest X-ray CT, enlarged pulmonary arteries, RV enlargement. Pulmonary function tests, detect lung disease. Ventilation perfusion VQ scan to exclude CTEP. Lab tests, BNP, NT-proBNP, autoimmune serology. Exercise testing, 6-minute walk test, cardiopulmonary exercise test. Number 12, nursing diagnosis, impaired gas exchange related to increased pulmonary pressure, activity intolerance related to fatigue and dyspnea, risk for decreased cardiac output related to right ventricular failure, anxiety related to chronic disease and prognosis, deficient knowledge regarding disease and self-care management. Number 13, medical management, general measures, oxygen therapy, diuretics for right heart failure, anticoagulants, especially in CTEP, digoxin in some cases, specific drug therapy, calcium channel blockers in vasoreactive patients, endothelin receptor antagonists, bosentan, ambrisentan, macitentan, phosphodiesterase 5 inhibitors, sildenafil, tadalafil, prostacyclin analogs, epoprostenol, treprostinil, iloprost, soluble guanylate cyclase stimulators, riociguat, surgical interventions, pulmonary endarterectomy for CTEP, balloon atrial septostomy, lung-heart-lung transplantation. Number 14, nursing management, assessment, monitor vital signs, oxygenation, fluid balance. Oxygen therapy, administer as prescribed. Activity modification, encourage rest, avoid strenuous activity. Dietary support, low-salt diet, fluid management. Medication adherence, educate patient on drug regimen, psychosocial support, counseling, support groups. Monitoring for complications, edema, arrhythmias, syncope. Number 15, treatment options. Pharmacologic therapies, vasodilators, anticoagulants, diuretics. Non-pharmacologic, O2 therapy, lifestyle modifications. Interventional, atrial septostomy. Surgical, pulmonary endarterectomy, transplantation. Number 16, psychosocial interventions. 1. Patient counseling. Education about disease, prognosis, lifestyle. 2. Support groups to reduce isolation. 3. Family counseling, coping with caregiver stress. 4. Vocational rehabilitation programs, adjust employment. 5. Spiritual support, coping with end-stage disease. 17. Prevention, early treatment of lung-heart diseases, avoidance of appetite suppressants and illicit drugs, smoking cessation, anticoagulation in high-risk patients, regular screening in patients with systemic sclerosis, congenital heart disease, healthy lifestyle, diet, exercise, weight management. Number 18. Conclusion. Pulmonary hypertension is a multifactorial, progressive condition that significantly impairs quality of life and survival. Advances in diagnostic techniques and targeted therapies have improved patient outcomes, but prognosis remains guarded, especially in advanced cases. A multidisciplinary approach involving physicians, nurses, psychologists, and family support is essential. Early recognition, proper classification, and individualized therapy can significantly improve quality of life and extend survival. Thank you. Have a nice day.